Good morning, ladies and gentlemen. Today we are going to talk on depression and heart disease, the morbidity, mortality, and intervention strategies. You see, this gentleman, what is the state of his mind? What is state of mind? Predict. He is totally hopeless, worthlessness, hopelessness is in his mind. He has sustained sadness of mood. He has loss of interest in all pleasurable activities, that's anhedonia. He has sustained sadness of mood, loss of interest in all pleasurable activities. He is very suicidal, therefore he is burning a fire that he will kill himself. So this is the state of depression actually. Depression is a very serious illness, and according to the World Health Organization prediction, depression and anxiety, sir, good morning, is going to afflict. Depression and anxiety is going to afflict the whole world. 50% of the population will be suffering from depression and anxiety and other psychiatric problems. So the psychiatrists are the rulers of the future. They will rule the world. So don't ever think that I will not do a PG in psychiatry. If you do PG in psychiatry, you will rule the world. You have choice to rule the mind. You see, there is hardly any difference between a Napoleon and a beggar. It is the mind. God has not given any different body to a Napoleon and a beggar. The Napoleon thinks, I can control the whole world, and beggar says, I have nothing, give me 10 paisa. So, the mind, the psychiatrists are going to rule the medical fraternity. And now also, if you go to the site of USA, psychiatrists in the first 12 highest earning doctors, there are 6 psychiatrists in USA. They have taken just now they have published in the first 12 doctors, 6 are psychiatrists, highest earning doctors. So psychiatry is going to rule the world, and because of this, you see the condition of the patient. He has sustained sadness of mood, hopelessness, worthlessness, lack of sleep, lack of energy, no interest in any work. He is contemplating to do suicide. Therefore, he has burnt his fire by his side. He has already burnt his fire by his side. He wants to kill himself. So this is the state of depression. And another more important is heart attack. Do you know? The cardiologists, they suffer from maximum number of heart attacks. It is a USA study. Cardiology profession is the most stressful profession, and psychiatrists are least stressless. So now there will be combination of cardiology and psychiatry, with the most stressful profession with the least stressful profession. So now we will be discussing about depression and heart disease. It has been since long, history has proven that the heart and mind has very interactive communication. If the heart is affected, the mind also. A troubled mind makes a heart more troubled, and a troubled heart also affects the mind. There is a lot of, if you go to Shakespearean novels, you will find all his novels are full of this. All the novels are full of how the heart pain affects the mind and mind pain affects the heart. In as old as 1628, English physician William Harvey noted that every affection of the mind that is attended either with pain or pleasure, hope or fear, is the cause of an agitation whose influence extends to the heart. Therefore, the dictum, troubled minds and troubled heart. This is true. Then depression and cardiac problems are a deadly combination. It kills the patient. Therefore, you, the doctor, should be aware of these facts. For the DSM students, these are the criteria of major depressive disorder. This is the DSM-4. Now DSM-5 will be coming within a year too. But this is the DSM-4 criteria that is ruling since 1992. This criteria, 1992, this is ruling. This is depressed mood most of the day for at least 2 weeks. For major depression. Depression are mild, moderate and severe. This is the criteria. Suppose somebody gives me some abuse. I feel sad. That is not depression. You have certain problem at your home. You feel little upset. That is not depression. Depression is sustained sadness of mood most of the day for at least 2 weeks. Or anhedonia, loss of interest in all form of pleasurable activities. The person won't have any interest to see television. It is a normal way to play golf. He will not go to play golf. If he is playing table tennis or lawn tennis, he will not go there. Then you must first ask whether he has now stopped performing his hobbies. This is the most important. You have seen that Munna Bhai MBBS, how that old patient, when you had brought a carom board, he immediately got up from the bed and started playing carom. If the person has stopped playing carom, that means the heart attack patient has started having depression. So one of the symptoms must be depressed mood or loss of interest in all pleasurable activities including hobbies. Nearly every day for 2 weeks to brand a person of major depressive disorder. Symptoms must cause impairment of functioning. That is most important. So I will now quote famous studies. I have gone to net, I have found about 300 studies on this subject. 300. Americans are most worried. We Indians don't worry because we have a lot of population. If people die, what is there? It is beneficial to us. So, in America, this is the Journal of Medical Association, 1993. It has studied 220 patients with a prospective evaluation. The patients who were admitted in the hospital had no depression at the time of incidents. They have given one group. Those who have prior depression before having viral infection, they are a separate group. They are studied prospectively. So they wanted to evaluate if the major depressive disorders in patients who are hospitalized, who have any independent impact on mortality for a 6-month follow-up. They found the 78% are male and 82% having previous MI also. They have previous MI. So they found depression was a significant predictor of mortality, odds ratio 5.74. That means if a person has prior depressive symptoms before a cardiac illness, the cardiac myocardial infarction is 6 times more likely to die. 6 times. Odds ratio tells that 5.74 means around 6. So depression, you know how killing it is. How killing. Controlling other, they found that it is still almost four times more, causes more death. So you see the graph of depressed and non-depressed. So there should be a strong connection between a cardiologist and psychiatrist for effective rehabilitation, for improving the mortality and morbidity of a cardiac illness patient. You see how dangerous the graph. Only depression. Non-depressed, you see. Another study, it is the Journal of Circulation. they did 18-month follow-up shows that the depression inventory and base depression inventory will consist significantly 18 months of cardiac mortality. Even after controlling for other predictor mortality, so the odds ratio was so high. Another study, it was published in American Journal of Cardiology. I have not intentionally given any psychiatric journal, because a psychiatrist talking, he must talk about cardiology journals. When a cardiology talks, he should talk about psychiatric journals. I have intentionally omitted because you will say the psychiatrists, they want more practice probably. Therefore, they have included their journals. No, it is all what the cardiologists are telling. It is published in American Journal of Cardiology. They followed age, high age, 1250 in America. 1250 is a very big number. In our country, 1250 is not a very big number. We study in lakhs, but the America, this is a very big study. They studied for 15.2 long years. Patients were in the time of fast onset of coronary artery disease and followed for 6 to 12 months, then annually. This is the result. Higher depression score associated with the increased risk of subsequent cardiac death and total mortality after controlling everything. Patients with moderate to severe depression have about 70%, that is 7 times greater odds of cardiac death and about 8% greater some mortality from all causes than the non-depressed patients. So you see how important to identify depression before, at the onset of cardiac illness, and if it is not present, then also you have to keep a close watch. After a cardiac illness also, if there is onset of depression, still the mortality and morbidity is higher. Another, they studied 280 patients, hospitalized patients. Those were hospitalized from also non-hospitalized. These were purely hospitalized patients. They followed for 5 to 10 years. Then, even after 10 years, the onset of depression has a greater risk in mortality and morbidity. So, you have no relaxation. Even if the patient is non-depressed, at the onset, at the admission of a coronary artery disease, you must keep a close watch. Whether at any point of time, the patient is developing sustained sadness of mood, hopelessness, worthlessness, reduced interest in all its pleasurable activities, including hobbies, you must be careful. It will cause him death, and the cardiologist will be blamed because patients don't believe they are mentally ill. All patients who are mentally ill, they say that we are normal. The doctor is. So this is published in the American Journal of Cardiology in 2008. So persistent symptoms of depression in acute coronary syndrome. They studied 425 hospitalized patients with acute coronary symptoms and followed 6 to 12 months later. They found out depression, those patients were depressed, has poorer risk of recovery. Many factors, I will tell later, there are several factors. They will intentionally don't obey the doctor's advice. When the doctor says, a depressed patient, if you stop medicine, no, you will die. They will be very happy at heart. At least I have found a way to kill myself. Because they have death wishes. I show you the first picture. They want to die, and the doctor gives them a weapon. If you stop this medicine, you will die. They will not follow your advice. They will stop medicine and tell that I am taking. You see how dangerous they are. And you will be blamed. Mind it. It is published in Archives of Internal Medicine 1998. 1190, here they studied the doctors. Probably they thought doctors will be better careful. doctors might have less depression, they might have thought. No, depression does not leave doctors also, not even psychiatrists. So there is a long observational study from 1948 to 1964, followed for 40 long years. They must be railway doctors. Otherwise, other doctors leave job very frequently. We don't leave job. We stay for 40 years. So they found that the odds ratio was almost 2 times higher, both in coronary artery disease and myocardial infarction. Even in doctors. Others it was 5 and 6 times death. But doctors, they were probably more careful. They were following the advice of cardiologists. Therefore, the odds ratio was still 2 times higher. Depression and medication adherence. It was it was published. So they have found that if the person is depressed, he is not likely to follow the doctor's advised regimen. You have to be better careful. You must instruct the relatives. Kindly keep a watch. The person must be keeping silently the medicine below his tongue and throwing away the moment the sister disappears. The person must be telling relatives, oh, I will take medicine, give me in my hand. And he must be silently observing. When the relative just goes over, he will throw it. Yes. That is the beauty of depressed patients. So you see, the graph you can realize it in a better way. So this a depressed patient also more likely to forget medication. And also they decide to skip. They don't take medicine as prescribed. So if you don't treat depression, you are going to be blamed for the increased mortality and morbidity of the patients. Then the question comes, does treatment of depression improve the outcome? Only treatment of depression plus, of course, a cardiac patient, you don't start prescribing antidepressants, stopping cardiac medicines. And if the person dies, don't blame psychiatrists. You have to be a very good cardiologist also. We don't claim that we treat heart attack patients. Then another wonder drug, tianeptine. One day I was sleeping and I was shouting tianeptine, tianeptine, tianeptine. My mistress told, what happened? So it is so much ingrained in my mind. Because why? Because this drug has least side effects. You can give kidney disease, renal disease patients, cardiac disease patients. So whenever at night any sister's phone call comes, no, I practiced. Immediately without my knowledge, the phone will answer tianeptine. Which drug to give? He would say tianeptine. That was the beauty of my mind. Therefore I was shouting to my missus, wanted to wake him up, and I was telling tianeptine, tianeptine. And the fixed dose schedule, 1 tablet twice daily. It is convenient for physicians also, patients also. In all, mild cardiac illness, moderate cardiac illness, severe cardiac illness, you don't have to worry. Just memorize tianeptine 1 tablet 8 hourly. And if the patient is above 80 years, then you reduce the 1 tablet twice daily. Or having severe renal impairment, then also you can give 1 tablet twice daily. So there is a famous trial. It is published in Journal of American Medical Association, JAMA. They have done study on this sertraline, the SAD-HART study that Dr. Jha must be knowing. Very beautiful study. It was worldwide study. They studied in 7 countries and for a long period from 1997 to 2001 to find out, to neutralize any cultural influences, environmental influences, individual influences. They negated everything. When the outcome are measured by these scales, you find that. So if you don't treat, this is the cumulative hazard. And after treatment with sertraline, there is a marked improvement in this group. Then, what does the treatment recommendation regarding depression in patients with coronary heart disease? What the cardiologists say, what the psychiatrists say, I am omitting. It was published in Journal of Circulation in 2008. It was a famous Littman study. They recommend screening, referral to a psychiatrist, and effective treatment of depression. With what the American Heart Association says, I will tell you. They recommend routine screening for depression in patients with coronary heart disease in various settings, including hospital, physician's office, clinic, cardiac rehabilitation, everywhere. And you will be very happy to note, screening for depression is very easy. Only 2 questions. You don't have to remember so many criteria. You don't have to remember so many guidelines. Just remember, ask the patient, how are you? Whether you have, how is your interest in your hobbies? Whether you are having pleasurable interaction with your children, of course, wife also. Beautiful, this is important. Whether you are going to your hobbies, simple, diagnosis clinched. So simple, 4 or 5 questions, and your success rate goes 6 to 7-fold. You see, only 2. You ask, over the past 2 weeks, how often you have been bothered by the following: little interest or loss of pleasure in doing things what you used to enjoy earlier, like playing carom, playing table tennis, playing football, playing cricket. Yes, most money-making profession. You should not forget cricket. So, if there is positive yes, you can improve his morbidity and mortality 6 to 7 times. If you don't treat, you are to be blamed. Remember these 2 questions. No more, no less. So, if you do positive screening, if you identify depression at the onset